Rugo from the University of California, San Francisco, and she's going to talk about treatment selection for patients with low and equivocal ER status.
Thanks very much, and thanks to the organizers for inviting me and for hosting such an amazing meeting with incredible speakers, really a fabulous and international population attending. So my topic was treatment selection for patients with low and equivocal ER status. Turns out this is a very controversial area, and we will discuss the data that exists as it is now. So there is a lot of controversy about the definition of how positive ER needs to be positive, and the impact of that result on treatment. Where do our guidelines come from? In 2010, the American Society of Clinical Oncology and the College of American Pathologists, called ASCO CAP, made the following guideline that ER is positive if there is at least 1% staining, and the term equivocal should not be used. This is based on data suggesting response to endocrine therapy in low ER-positive disease that I'll show you in just a moment, and the algorithm is shown here below. There is actually the same group plus some shifting, has gotten together recently once to review the guidelines and see if there needs to be any updates. So how did we come about with this definition? Well, actually, we're here standing on the shoulders of giants, one of whom is on the stage, not to suggest that Hervé is not, but almost 2,000 primary breast cancer samples were evaluated and published in a paper in 1999. This really seminal paper led to the change from ligand binding assays to the recommendation for using IHC, immunohistochemistry, to determine estrogen receptor positivity. In this paper, frozen tissue sections that were left over after the LBA were pulverized under cold temperatures, and IHC was performed, and then ER was scored using the all-red score, where 3 to 5 could be defined as low ER. As you can see, patients who had any degree of ER positivity had a better outcome than patients who were classified as ER negative by this IHC technique. There was a subset of patients, about 500, who received adjuvant endocrine therapy alone. In that group of patients, patients who had ER positivity of any amount had an improved disease-free and overall survival that was highly statistically significant. This data was then incorporated into the ASCO guidelines. So the details of testing actually included really important changes that really came about because of understanding how to test for HER2. And this included not only ruling out false negatives or false positives in terms of the progesterone receptor, but also determining what was an adequate cold ischemia or fixation time, that it couldn't be too short or too long, because that would give you potentially false results. These are optimal characteristics in our guidelines for any IHC test, including ER, PR, and HER2. The H-score, all-red score, or a quick score could be provided, and then interpreters of estrogen receptor and progesterone positivity need a way to maintain consistency and competency. What's really interesting, and I thank Fraser Simmons for this information and discussing my slides with me, is that evolving technology with immunohistochemical techniques and antibodies has improved the sensitivity for testing for ER. And also for PR, of course, but we're focusing on ER on this slide. I've put a box around what could be considered low ER at an all-red score of 3, 4, and 5. And what you can see is the original paper I just showed you in red that shows you what the all-red score was with a sort of bump around 5 and 6. And then some 7, less 8. But as you change to these different monoclonal antibodies, 1D5 and SP1, in 2011 probably the widest used current antibody, you can see that the number of patients who have strongly positive tumors for ER has gone up significantly over time. So that using either the 1D5 or SP1, there are many more patients who have scores of 7 or 8 compared to those who have scores of 3, 4, and 5. You can see that's a small number in current testing. So what's the biology of these tumors? It's important to keep in mind as we talk about biology and prognosis that testing has changed over time, and very few studies use central confirmation to assess the percentage or quantitative ER positivity. So this is a study from MD Anderson published in 2012, and much of the data that we will talk about comes from retrospective review of a various number of patient samples from MD Anderson, where they have an extensive patient database. So they looked at estrogen receptor by immunohistochemistry, ESR1 by messenger RNA, so estrogen receptor expression, and molecular class by PAM50. 5.4% of the patients had ER low, defined as 1 to 9%, and that's only 25 patients, and you'll see that this will be true across the data sets that we'll look at. Of this group of patients, 33% had HER2-positive disease, and that impacts both looking at intrinsic subtyping as well as outcome in the patients that we'll review. So if you look at the purple box, you can see that the patients who had low ER, about 76% of them did not have any ER expression by messenger RNA, and 24% were positive, already suggesting that this is a heterogeneous population of tumors. Similar data was published from a group in India, where they saw 48% of patients had tumors with no expression of the estrogen receptor by messenger RNA, and I'll show you one other data set that has similar data in just a moment. They also looked at the intrinsic subtype using PAM50. Now remember that 33% of the patients had HER2-positive disease, and those patients largely have HER2-enriched disease because ER is low, and we see an increase of the HER2-enriched intrinsic subtype in those patients. 48% had basal-like tumors, but 8% were luminal B and 12% normal-like. If you remove the HER2-positive cases, 71% were basal. The best analysis of the biology of low ER-positive disease was done with this combined analysis from BIG and the North American Breast Group. Chang looked at 3 different trial populations, and you can see the number of samples that were available in each trial, as well as the treatments that were evaluated in each of these studies. This trial reviewed ER, PR, and HER2 centrally, which the other studies generally did not do, in about 1,500 patients. 39 of those patients had an ER/PR that was considered low, from 1 to 9%, and that represented only 2.5% of these trial populations. Intrinsic subtyping could be done in almost 1,700 patients with PAM50. This shows you the results that were published in The Oncologist in 2015, showing that basal-like tumors were seen in only 18%, HER2-enriched in 31%, and then the combination of luminal B and luminal A represented a large fraction of these patients who have low ER-positive disease. In the patients who had HER2-negative disease and hormone receptor-negative disease, triple-negative breast cancer, 73% were basal, and in the patients who had hormone receptor-low and HER2-positive, more than 3/4 had HER2-enriched disease. So we're already seeing a lot of heterogeneity, and this graph even shows more, this dot plot, showing the proliferation index by PAM50 and the luminal cluster gene signature. And if you look at the second curve over, the second column over, you can see that's the HER2 low, hormone receptor low, HER2 negative group. And what you can see is there are a lot of colors in those little plus signs. And what that means is that you're seeing a smattering of basal-like, HER2-enriched, and luminal disease within these different signatures. There's additional gene expression data, which I've summarized here. Much of it is complicated because HER2-positive disease is included but not specified in terms of the number of patients, and different scoring systems were used, including all red and then the ER positivity by so-called quick testing. What you can see is that the basal-like population, if you just look at the far right column and look at the basal-like group, it varies from about 50%, 40% to up to 84%, depending on the population of tumors that are evaluated. Remember that in many of these cases, ER was not reviewed centrally, and this is a group of tumors where you may see differential testing based on the eyes of the beholder as well as the fixation time and staining method. And then there's data actually looking at the recurrence score, which is quite interesting. And what you can see if you look at the upper right-hand box is that ER status, as you can see the estrogen receptor, looking at messenger RNA and RT-PCR, you can see that of the patients who have borderline ER, so low 1 to 10%, 56% of them had no expression of RNA for the estrogen receptor. Then if you look at the recurrence score group, what's interesting is that none of these tumors fall into the low-risk group, as you would expect in this scoring system that's heavily weighted on expression of ER, but they mostly fall into the high-risk group, as you can see in the dot plot, where most of them are falling above the previous scoring system for high. And if you move that down a little bit for our current scoring system for high, there would be even more, with only a few cases in one handful that are in the borderline intermediate group. So what's the prognosis of patients who have low hormone receptor positive breast cancer? Well, this is data from ATAC from 2008 that looked at different quartiles using the H-score to evaluate ER. And if you look at the solid line, which is the lowest quartile, in patients treated with tamoxifen or aromatase inhibitor with either ER or PR, you can see that those patients clearly had a worse prognosis than patients who had higher levels of ER or PR, even though all of these patients received hormone therapy. Anastrozole was better in all subgroups, and there wasn't any variation in the degree that anastrozole was better based on the H-score or quartile for hormone receptor positivity. A meta-analysis was published last year looking at studies through November of 2016. 6 studies were included. They required reporting of ER by percentage, but not PR or HER2 to include the analyses. What you can see is if you look at the disease-free survival and overall survival with the little boxes, you can see that it appears that there's perhaps a slightly better prognosis looking at the patients in these studies who had low ER compared to those patients who were truly ER negative, less than 1%. And remember the highly variable use of endocrine therapy in these populations of patients. If you look at the use of endocrine therapy, the only difference that was statistically significant with a p-value 0.034 was looking at disease-free survival with endocrine therapy in patients who were ER borderline versus those who had scores of 10% or greater. Of course, showing that hormone therapy is more effective in patients who have stronger tests for ER and PR positivity. Overall survival in patients who had borderline ER looking at endocrine therapy versus not didn't show any significant difference, but I've given you more details about that patient population in the lower right-hand corner, and what you can see is that only 40 or 20% of the patients received endocrine therapy, and the number of patients who had low ER disease was quite small. And again, we're mixing a little bit of the PR and HER2 in these groups of patients as well. What about neoadjuvant therapy? We've used neoadjuvant therapy as a way to assess chemotherapy sensitivity, and we know that patients who have luminal-like disease tend to have very low rates of pathologic complete response to neoadjuvant chemotherapy. This study from Pittsburgh in the United States looked at patients who received neoadjuvant chemotherapy. What they showed was that in the 41 patients who had a low H-score for ER, the pathologic CR rate was 37%, more similar to what we would expect to see in a true triple-negative breast cancer population. If you look at the patients who had no pathologic complete response, the patients with low ER track along with the patients who had ER-negative disease. Another study from MD Anderson looked at patients who received neoadjuvant chemotherapy for stage 2 and 3 HER2-negative breast cancer. 5.6% had low ER. 28% of those patients had a pathologic complete response, again, showing that these patients have more chemotherapy-sensitive disease. About a quarter of them received adjuvant endocrine therapy. They found that PCR in ER low was significantly greater than in patients who had strongly ER positive disease defined as 10% or greater, And a multivariate Cox regression analysis based on endocrine therapy, again, this is a retrospective review, found that there was no significant difference in time to relapse or overall survival based on use of endocrine therapy. But again, looking retrospectively could be biased by the percentage of hormone receptor positivity, but they did take into account PCR or not in this multivariate analysis. This shows you the outcome of these patients, regardless of treatment or PCR, based on the ER category. The top graphs look at ER that's negative, so triple negative, ER that's between 1% and less than 10%, and ER of 10% or greater, showing again that the triple negatives and the low ERs track along together, different from the strongly ER positive group. And then if you look at the ER less than 10% or 10% or greater, on the bottom curves, you can see also a significant separation on the time to recurrence and overall survival, regardless of the fact that these patients all received neoadjuvant chemotherapy, and patients who had low ER disease had a higher PCR rate. Recently, we saw data from the Carolina subgroup, Carolina study done in North Carolina that was presented at San Antonio. In this group of patients, they evaluated the patients who had ER low disease, defined as 1 to 10%, and looked at outcome, disease-free survival, based on endocrine treatment or not. Here, their data suggests that patients who did not receive endocrine therapy, who were in the borderline group, had a significantly higher chance of recurrence, a disease-free survival event, than those who did receive endocrine therapy. The hazard ratio models are listed there, with Model 2 including the risk of recurrence score. This is a heterogeneous population and again includes HER2-positive disease as well, yet it does suggest some benefit from hormone therapy in some subset of patients with borderline ER-positive disease. And then lastly, a recent publication looked at the risk of late recurrence based on ER, again from MD Anderson. You can see that the green curve are the triple-negative patients. We tend to tell patients if they're 5 years out and they have triple-negative disease that they have a vanishingly small risk of recurrence. The patients who had low ER, as 1 to 9%, seem to have more recurrence. But if you look at the numbers on the bottom and you go out to 6 years, the curves are almost identical. So it does appear, in fact, that there are very rare late recurrences in patients who have low ER-positive disease. In addition, the caveat to this data is about 29% of patients had missing percentage information, and the numbers at the bottom, which say 1428, are really 873 based on their consort diagram. But it doesn't really change the curves. I think that if you go out to 6 years, you see about the same recurrence late in these two populations. So what's a summary of all of this data and the implications for treatment? We know that low hormone receptor positive disease is relatively uncommon, representing about 2.5 to 5% of breast cancers that we see now. It's a heterogeneous subtype of breast cancer by intrinsic subtyping and also looking at the studies evaluating disease-free and overall survival. Low hormone receptor positive expression is associated with higher risk clinicopathologic factors, higher Ki-67, grade, and less PR positivity. It's also associated with a higher recurrence score. Do these patients have an intermediate prognosis? They certainly have higher chemotherapy sensitivity, demonstrated by the several studies looking at PCR rates, and the hormone sensitivity is still poorly understood. The caveats are that all of these are retrospective data sets, and only one study prospectively evaluated the staining for ER, PR, and HER2. So what are our questions? Low ER is generally defined by IHC either less than or equal to 10% or 9.5% if you're at MD Anderson. Further definition would be very interesting, but it's challenging due to the small numbers of patients and the fact that we're never going to do a prospective trial looking at hormone therapy or not in any population of patients who have hormone receptor positive disease. These tumors are indeed quite heterogeneous by gene expression profiling, and clearly the number of patients who have low ER and basal-like intrinsic subtype are much smaller than what we see in patients who have true triple-negative disease defined by ER and PR less than 1%. So what determines endocrine responsiveness? It might be percent estrogen receptor positivity. One study looked at 1 to 5% versus 6 to 10% and suggested a hint of responsiveness to endocrine therapy in a retrospective review in tumors that were slightly higher in 6 to 10%. But what I showed you earlier is that with new antibodies and new testing requirements, we really are seeing such a tiny number of patients who fall into that category. That would be quite a difficult differentiation to make. What about gene expression profiling? It may be that patients who have basal-like disease don't respond to endocrine therapy at all. But how we're going to determine this is quite difficult because, again, we'd have to randomize these patients not to receive endocrine therapy. I will note that something that was in the St. Gallen paper last time and was mentioned here is that high genomic risk should potentially be used as a factor to determine extended adjuvant endocrine therapy. But it clearly isn't the only reason to recommend extended adjuvant endocrine therapy because patients who have low ER and PR are likely to gain very little benefit from extending endocrine therapy past 5 years. So what are my recommendations based on this data? For chemotherapy, I think adequate data exists to recommend that chemotherapy be given following guidelines for triple-negative breast cancer. Endocrine therapy, of course, is the major question and much more difficult. Unknown benefit, but we can't rule out a benefit. So in general, endocrine therapy should be recommended, although I think it's likely that the benefit is extremely small in very low ER-positive disease, less than 5%. Although this tumor is not really triple negative, it has a lot of similar features. Similar chemotherapy sensitivity and probably low response to endocrine therapy. And I would propose that tumors that have an ER and PR less than or equal to 5% be considered for inclusion in triple-negative breast cancer clinical trials. Right now, they fall into no man's land, no person's land. They aren't eligible for most studies. And it's a reminder also to always repeat the test. Thanks very much.
Questions or comments? I think the comment I would make is, why mess with a good test? The test that we published in 1999 correlated well with quantitative dextroamphetamine charcoal assays. It correlated well with other factors at the time, Ki-67, progesterone receptor expression, and it was a good test. There were very few false negatives because the the responses in the negative group are very, very low. So why would you want to have a more sensitive test? It made no sense at the time, other than a company wanted to say their test was more sensitive, so they were able to make a more sensitive test and market it, and that's why things changed. And now we don't know where we are now, as you pointed out. I think the data from MD Anderson that shows that the low or borderline ER positive group has late recurrences would suggest that they are not triple-negative breast cancer. And it's a mixture of probably low ER positive and triple-negative, and you get a sort of an intermediate result there. So I think we're in a bad way with this. I think we don't understand it. I wish we could go back to the assay that Allred developed a long time ago.
It's actually all the fault of HER2 testing. That's why things changed. Everybody was looking for more sensitive assays for everything and correlating it with response. I think the data about late recurrence has to be taken with caution. Again, a lot of patients didn't have the percent receptor actually detailed. They didn't go back and look at them again. And then the number of late relapses is exceedingly small and way smaller than you would expect from a ER positive population at greater than 10%.
Ken. Microphone 7. Hi, Johannesburg, Karolinska. I hope, Rugo, that you have got this very nicely correct. I think there is quite compelling data that the group 1 to 10%, there is really no proven sound effect of endocrine effectiveness in that group. And I will cite the BIG-NABCG article from 2011 with 21,000 patients. 4,700 were determined to be in the low range using the biochemical assay, and that was 10 femtomolar or less they had no benefit whatsoever by 5 years of tamoxifen. Although I, of course, acknowledge the Harvey study, but there are prospective studies using tamoxifen versus nothing, can't demonstrating an effect in the very low risk group. And the microarray data is really supporting that quite a proportion of these patients really have a different biology.
Thank you, Jonas. Before we move to the next speaker, I think that your point regarding the fact that we should rebiopsy these patients in case of relapse is, of course, crucial but obvious for everybody in the room. But thank you. Yeah.
And retest for ER if it doesn't seem like it's the right answer.